Well, good afternoon, everybody. This is Jason Belden, the Director of Emergency Preparedness for the California Association of Health Facilities, and you've joined us for our CAF COVID Weekly Roundup. I forgot to update the title slide. I apologize. Today is not September 4th. It is September 11th, and it is 1 o'clock in the afternoon. And we have some guest speakers today. There's a group of folks from Medline who are going to join us and talk about the POC testing devices and the supply chain around those devices, as well as maybe a look at some of the other supply chain issues. But we'll get to that in the second half of the webinar. The first half, we're going to cover an update, what we know on the point of care testing AFL or the testing AFL. We anticipate that's going to drop any day now. Sadly, it did not arrive this week, but we have a good idea of what we anticipate is going to be in the AFL, and so we'll go over what we anticipate, and I think that's very important for you guys. For planning purposes, we'll talk about some of the things you should be doing now in order to get ready for that testing AFL. We have not talked about this on any of the webinars up to this point, but it's never too early to start talking about recovery. And when we talk about recovery in a disaster or something of this nature, it's going to be very layered. And even if you guys aren't practicing incident command, we'll talk about some of the elements you should be items you should be capturing in order to ease your recovery process. So we'll go over all that stuff. And then if you're looking for resources from CAF, CAF has a separate website or a web page devoted just to the coronavirus updates. And that's at the website that you see there. All right, so just a little introductions. The speakers' opinions expressed are their own. That includes me. It may not reflect CAF's official position. Our program, meaning the program that I manage for CAF, is a grant-funded program, which means that we offer these services in these webinars to all skilled nursing facilities, regardless of membership. I have no financial conflicts. I'm employed by CAF under that grant. And just as a side note, well, you know what? I'll save that for the end of the webinar. But the intent of the webinars is we generally want to give you a situational report based on what we see occurring in and around COVID response for skilled nursing facilities. We talk a little bit about forecasting and developing planning tools to deal with where we think the event is going to go. And then when we get a chance, we like to highlight best practices. And that's why we have the folks from Medline with us. They'll talk about these devices because it's going to be a really crucial part of how you meet the testing requirements. So we want to cover that in depth. And it's more than just the device itself. And we'll talk about that in a minute here. So, all right, so what's new? Well, I can't even remember the last time we've done one of these webinars that did not have an AFL, at least one AFL that we did not go over in depth. But this week is the first week that I can remember that we've not had an all facilities letter that talks about a regulatory or a policy change. So no AFL is both good news and bad news. What we do know is we know that from our communications with CDPH that they're going to move to a weekly testing modality for everybody. And so even the counties which have a lower transmission rate than what the feds had set up, meaning the under 5% would be testing once a month, just like we're currently doing. CDPH has let us know that the testing, while once a month was developed because of the resource limitations of the whole testing process, whether it be reagents or pipettes or transport media or the labs themselves. There were always issues with trying to get testing, and that was why they chose the once a month testing, because that's the only thing that they thought was reasonably accomplishable based on the resources and supplies that we had at the moment. They feel like those resources and supplies are better now, both from a lab side and from a POC testing side, and we'll talk about that. But from the lab side, they've really started to see an increase in the ability to meet the time frame turnaround goals for PCR testing. So we know that for at least a broad swath of the state, the access to those testing resources seems to have improved. Now, that's not everybody, obviously, and whenever the state makes a decision like that, it's meant in an aggregate, and we know there are going to be people that are not going to be able to meet that needs. And so one of the other important things that we do know is that we want you to test, and it's incredibly important to make sure that we understand, you know, how COVID, you know, whether we have COVID in the building and how to appropriately cohort those folks and minimize the risk, and let our infection control policies and procedures that we've developed help us, you know, mitigate the spread once it gets into our building. So we know that the testing is important. We know that best practice really would be once a week. We just haven't had the resources to go to once a week. And now the state feels like with a combination of both traditional labs, POC devices, better education and understanding of how to go through the process, that things have gotten at least good enough that we can start on this weekly testing almost immediately. And so what is likely is that when the testing AFL comes out, it will likely be a very quick turnaround for you guys to be up to speed with the testing. So that means you may have 7 days or 10 days to really get your testing process and plan in place prior to a surveyor showing up to look to see that you have it in place. So what do you need to do now in order to prepare for that? Now, hopefully you've already at least begun some of these processes, but if you've not, you've got to contact the labs that you currently do business with and talk to them about the increase in capacity that you'll need, because you're not going to be doing, you're basically going to be doing 4 times as much testing as you have previously done with your lab partner. So that is a big question. Like, okay, I'm doing, you know, 40 tests a week with you. Now, if I do 120 or 160, what does that look like? Or do you have the capacity to do that? And if not, then we've got to start searching for backups. And the backups you need to have no matter what, even if the lab you say you have a contract with says, yes, I have plenty of throughput and I can get you those results back, I still strongly encourage you to have multiple backups to that. As we've learned, these can, you know, kind of go in a cyclical or a wave process. So they may have plenty of all their supplies and they may have plenty of capacity now, but you don't know who else they're contracted with. You don't know who else is going to use their service. So really, it's important for us to not only understand whether our current lab can meet our needs, but also who can we turn to as a backup. When we talk to these labs, we want to be clear when we discuss the billing. We don't want any things on the back end hanging us up. Talk about the limitations. You know, are there limitations to who they can bill? Are there some of the health insurance plans having problem? Are they having problems, and are they then passing those problems on to you? If you're still doing business with a lab that's forcing you to pay for your staff rather than doing the internal billing, as we ramp up the testing for this, any costs that you're currently experiencing as a result of that are going to, you know, potentially quadruple, and maybe even more than that if you're in one of the counties that's in the red. And then we need you guys to document costs on uninsured or self-insured healthcare workers. You still have to get those folks tested. I've not heard a good manner of how folks are paying for this. We assume you're paying for it with the CARES Act or one of the tranches of funding. But you need to keep good documentation on how much of that, how much of those costs you are incurring. And when we talk about the billing and all that stuff, gosh, I am really limited, or I should say ignorant of all the different funding tranches. And it's so confusing at times that I think we will have some actual education just around that. Even if you're not a biller, or even if you don't work for your corporate office in a billing instance, I think it's important for you as administrators or planning chiefs to kind of look at that stuff, because if you understand the documentation that you're going to be expected to be able to provide to justify those costs, that'll help you when you do your response and how you document that stuff. So it's important. We'll have Jeff Sandman and Jennifer Breen, the regulatory department from CAF, will be presenting on this format in 2 weeks from now on the 25th, and they'll have a full presentation on capturing documentation, especially when we talk about recovery and what kind of paperwork we need to keep. One of the things we haven't talked about, and which you're already doing, you're planning. You've got a plan to collect and process tests. That plan and that those kind of logistical issues with doing the specimen collection, where you're keeping it, where you're processing it, when you're doing the tests of your healthcare workers, all of those things need to be planned out, because you're going to, like I said, you're going to rapidly expand the amount of tests you're going to be collecting from your staff. Now, if you have a lab partner that's coming in to do all of that, that will greatly save some of the time, for you internally to collect and process those tests and get them mailed out. That will definitely save you some time. But if not, you really, really, really need to kind of factor in the time it's going to take you to incorporate the antigen devices. And Craig, Doug, and John are going to talk in a little bit about what does that look like, the use of the devices and things like that. But it's a time-consuming process. We've done some initial calculations on what we think it will cost in terms of staff time to be able to process all the tests, given what we anticipate to come out and be a part of the AFL. We're essentially anticipating a full-time employee. 37.2 hours was approximately the amount of time that we had kind of quantified for the time it takes to collect the tests and process the tests and get them sent off. Or the whole gamut really is going to require virtually a full-time person. And whatever you're going to, the chances are you're going to be using a combination of both of these types of testing. And we'll talk about the limitations of antigen and why that may actually, you may not be able to get throughput, or maybe there's a supply chain side with gathering stuff that goes with the point of care devices. And so you may need to be able to be flexible to go back and forth between what is working and what isn't working. So it's important for you to practice competency in both. And I'll leave it up to Craig and Doug and John to talk about maybe, their recommendations of how you should practice before you start. But I definitely think you need to get everything out of the box, make sure it's working, discover any issues with the operations of the equipment before you even start using it for testing. All right, we know that a part of the testing AFL, the real part that we've never done, or that most of us have never done, some of us may have had experience in labs or in acute hospitals where we've done this, but traditionally we're not, we don't do the lab reporting stuff. And there's a help page by CalReady that has a bunch of frequently asked questions. I'm a visual learner, so for you guys, if you're like me and you like to watch somebody actually do what needs to be done, when I wanted to learn how to change a piece of equipment on my car, I watched a YouTube video, and that's how I learned how to do it. And so that CDPH IP webinars that's done with HSAG, they had a recording, and it's the slides are linked on that bottom link there. But you can go back and watch the recording at that link there. Or if you want to watch any of the HSAG recordings, you can go to that link and scroll to the bottom, and they have all the previous ones. They have both the slide decks and the webinars. My suggestion is for whoever's going to do your reporting, or if you have multiple people doing your reporting, have them watch just that portion of the webinar, and that should at least help them. On that CalReady page, there's a contact information. There's both an email address and a phone number for help getting set up with things. So I want to get that out to you. And the page deck or the slide deck is informative, but I like to watch it being done and listen to the audio. It's actually pretty good. So hopefully you guys will find some value in that one. I wanted to bring you another piece of news. Cal OSHA has, if you didn't know this, or if maybe you know this because you've already been visited by somebody from Cal OSHA, but Cal OSHA is in enforcement mode. They issued a press release. They did cite one healthcare facility. I will say that healthcare facility has a strong union presence. So if you have a union building, you're probably a little more at risk for having Cal OSHA visits than not. But in either case, they only had one citation that they highlighted from a healthcare entity. It was actually an acute care hospital. But it was specifically for not wearing or not supplying an N95 mask to a healthcare worker who was transporting a person from one portion of the health facility to another. And so that seemed tailor-made or very similar to a circumstance that we could see in skilled nursing. So I just want you guys to be cognizant of that. There are bright spots to that announcement. It doesn't sound like it, but the bright spot is they've done 8,000 inspections, and that was the only health facility that they had highlighted as in their press release. So that generally means that maybe their focus is on other stuff, and really agriculture and food processing seems to be a real focus for Cal OSHA at this point. So, and if you've not already downloaded this, Cal OSHA's guidance for respirator shortages is on there. I know that surveyors frequently watch the HAI calls, and they listen to the provider calls on Tuesday morning and the infection prevention calls on Thursday afternoon. And I know that some of the surveyors listen to Cal OSHA give their presentation about respirator shortages. And Cal OSHA, one of the things they had mentioned was that we feel like people should go back to the disposable use of N95s. And I just want, and maybe Craig and the folks from Medline could talk about towards the end of their presentation, whether if we all of a sudden switch to disposable respirator use, how quickly would we run into the same supply chain problems? I just want you guys to know that if you're issued a citation for extended use of N95s, please let us know, because that is not the direction we've been given by CDPH. It contradicts what's in their AFL as well as what's in this PDF from Cal OSHA. So we want to know about those if you get those. So, all right, I'm gonna talk about planning for recovery just for 2 or 3 minutes here. The reason why I want to talk about planning for recovery is because if we understand the things that we need in our recovery process, it will help fill in the gaps of what we collect. And when we think about how we want to end our response to COVID. We want to collect all documentation. If you're doing incident command, this would be the responsibility of your planning chief. We need coordination and submission of response and recovery costs. This is going to be incredibly important, especially if you're using CARES Act funding. There's a lot of gray area there in terms of how you spend your money, how you quantify that expense. There are expenses for lost revenue, all kinds of stuff that's very nuanced that you're going to have to get a hold of to protect yourself on the back end from audits and things like that. So conduct staff briefings. So if you're not already doing that, and hopefully you're doing daily briefings with your command staff or your response team, or however you want to do it. But when you get to the end, we want to talk about accomplishments. And hopefully as you've gone through COVID, you're implementing improvement issues and response issues immediately. If you've identified an issue within your command structure, that's what incident command is all about. That's what responding is all about. It's changing based on the conditions. So you'll need to have those quantified as well as when you changed what. Identification of needed revisions. So whatever those revisions were to your emergency plans, whether you created new job action sheets, whatever procedures you created in response to COVID, you want to collect those, keep them in a timeline format to let them know, so that you can kind of document when things changed and when you responded to those changes. We're all going to have to do an after action report and an improvement plan. And as we get closer to the end of our response, we'll definitely spend an hour on one of these webinars just talking about capturing the information for after action report and improvement plans, especially in light of the fact that we have no liability waiver, and because these will eventually probably make it into public documents. How do we quantify what we need to improve without realistically putting ourselves at risk to be sued for mistakes that were made. So that'll be a really important webinar come towards the end there. When you get to the end, you're going to want to participate in any external meetings, post-incident briefings. The important ones are education information for residents, staff, and family. Start thinking about how you want to communicate, tell the story of how you felt like you responded to the incident, something positive to give your residents, staff, and family members for the future. And so I wanted to talk about, these are just some of the items that go into recovery from an incident commander standpoint or somebody that's in charge of your response. These are 100% you're going to have to do all of this stuff. For other folks within your command staff, there are other issues that they can cover. So before I get to my last slide, I want to turn it over to John, Craig, and Doug. And I'm sorry, there's actually 4 folks, and I'm terrible with names, and I apologize if I left somebody out. But I want to turn it over to the folks from Medline to give their presentation, and then we'll get to some questions after that. And John, are you going to go first, or Craig?
Yeah, I'll just welcome everybody and introduce everybody to the team and let Doug take over. But I'm John Butterfield. I'm the division sales director for all of California and Nevada for Medline on the post-acute side. And today we've been talking with Jason, and we wanted just to provide really an overall lab update, a market update overview, and hopefully just arm everybody on the phone with some information to help you through this pandemic in retrospect to lab testing. So on the phone with me today, I have Brian Schreiber. Brian is a division manager for post-acute down, and he covers the Southern California market. And then I have Craig Hatcher. He's our lab specialist for the Pacific Northwest and Northern California. And then Doug is going to lead this call, and Doug is the VP of our non-acute lab heat division, which he covers the entire country, and he's providing us the update moving forward. Doug, you want to take it away?
Yeah, thank you, John, and I appreciate that, the introduction. So welcome everybody. The goal here really is to let you know what's happening today in the lab market in regards to COVID testing. So just a few quick slides. We're going to talk about PCR technology, antigen technology. We'll talk about the devices that you've received or are going to receive. And of course, we'll talk about the $5 test that Abbott has come to the market with. We'll have questions at the end. So if you have questions, please put them into the chat and more than happy to answer any questions you might have. Keep in mind, this market continues to change on a daily basis. But I can tell you, and I want you to be aware if you're not aware, that there is PCR technology available today. When I say available today, I'll talk about that. But what I mean by available today is that it's EUA approved for CLIA testing in the post-acute market. So PCR testing is the gold standard. This is the type of testing that the reference labs are utilizing today, that the government facilities are utilizing today. This is the only PCR device that is CLIA waived today. And you can see the device, it's fairly small. There's a 4-door or a 2-door. It's called the Cepheid GeneXpert Express system. Being PCR technology, it's very sensitive, specific, so very good. Today, Cepheid is developing a 4-in-1 assay. So one assay that will do flu A, flu B, RSV, and COVID. They're still waiting for EUA approval, but that is the way the market is actually going. The tough thing about this particular test is that even if you're interested in this device today, and I can tell you we've already shipped hundreds upon hundreds of these devices into post-acute facilities, but the problem is that the assay is not readily available. So even if you had this device today, we're probably still looking limited availability for the assay until we get to January, late December. At that point, Cepheid believes that they'll be able to handle about 90% of the product that's actually needed for this device in the marketplace. So if you're interested in this technology for the future, you can always get in line today for this technology. We're looking at January is more likely the time that you'd actually be able to utilize this technology. And if I look at this technology, PCR technology, and I contrast that with the technology, antigen technology, that I know a lot of you are aware of, the government basically decided to send 13,000 BD Veritor Plus to post-acute facilities across the country and 2,000 at the Quidel Sophias. We'll talk about both technologies, but this technology is antigen technology. So the benefit of antigen technology is the speed. So you can get test results fairly quickly. The previous slide, when I talked about the Cepheid device, it's going to take you 30 to 45 minutes to get a result, but you have higher sensitivity and specificity. I'm sure you've heard a lot about this. This particular test, it's got an 84% sensitivity. So basically, if I tested 100 patients, that means at 16, I said they're negative, we presume that they're negative, but potentially we misdiagnosed the patient. Now, CMS basically has come out to say, listen, this technology is still better than you waiting 48 to 72 hours for a result from a reference lab. So we'd rather you utilize this technology than wait for a reference lab that is taking a long time to get the results back. What it's very good at doing with most of these technologies, if it calls you positive, typically you're positive. There's very few false positives. So that's the true benefit. If you're positive, you're positive. If you're negative and I'm symptomatic, so I'm coughing, wheezing, high temp, I'd want a reflex to PCR technology. So to the Cepheid device or to a reference lab. And that Cepheid device, that system itself is used in a lot of these reference labs today. The nice thing about this device, the BD Veritor, it's fairly inexpensive. It's $330. It has limited use. It's good for 3,500 tests, and that it is a disposable unit. So once it gets to about 100 tests, it will start to click down, and eventually you'll have to get a new meter. The reagents themselves, 30 per box. They include a nasal swab. So it's truly a nasal swab. That nasal swab goes into some liquid. It goes into this cartridge you can see on the right side of the device. And their first result will take 15 minutes. The nice thing is, though, you can incubate the samples. So I could actually have a bunch of these little cards, these cartridges, next to the device. And once it reads the first test, I could continue to put the slides into the side of the device. And about every minute, you'll get a result. So at that point, you could do up to 30 or more per hour. The really good thing about this is that we started to receive the assays in our warehouse yesterday. There was a delay because the government came in under the Defense Production Act and took the initial stock from BD, but we now have this assay in our warehouses, and we'll continue to have it week after week. We continue to get more of these assays. So we have a long line waiting for this product today, but if you're interested in this product, you can simply order this, and eventually within the next 2 to 3 weeks, if nothing happens, and I'm very cautious to say that because things tend to happen that changes the market on a daily basis, but it is at least a monitor where you can start to get assays when needed. Now, some of you have received the Quidel Sofia 2, very similar technology. The sensitivity and specificity are greater than they are with the BD Veritor system. Simple to utilize, nasal swab goes into the system, you've got a result within 15 minutes. And I should also mention, be it the BD Veritor or the Quidel Sofia or the Cepheid device, all these devices can also do flu, strep, and RSV. This particular device, if you're interested in the product, you can order that through Medline, but it's a little different. So what happens is you'll let us know how many assays, reagents, same principle, you're interested in, and then we go to Quidel and we'll tell them this, and then they'll allocate us an amount of assays for your particular situation. I can tell you, Quidel, they still have not, the production is not where it needs to be today. So, for example, if you wanted 100 boxes, more than likely you're going to get a percentage of that. So maybe you'll get 50, maybe you'll get 30. We really don't know until we input that order with Quidel. I truly believe between the Quidel Sofia unit and the BD, if you had both of these technologies, that between the two of them, at least today, you'd be able to get those assays that you needed to actually be able to test your patient population, obviously the folks that are coming through your homes. I also wanted to address, because there's a lot of buzz obviously in the industry about this Abbott $5 test, an antigen test. Sensitivity, specificity are very good, but the confusing part at this point is that we're not exactly sure where this product is going to go. I can tell you what we've heard, what we've been told, but the government has this product. Before it was announced, Abbott is a partner of ours. They came to us and they said, listen, we've got the capacity to make 50 million tests a month. So obviously, HHS purchases 150 million. They have taken the first 3 months of sample. Initially, HHS said that the majority of these $5 test kits will go to K-12, it'll go to higher education, and it'll go to the first responders. And then about, I don't know, maybe 3 days ago, HHS basically said that a lot of this is going to go to assisted living. And then a few days ago, an article came out basically stating that 750,000 of these tests are going to go to the red, yellow, or green counties where they most need them. That's where 750,000 will go. But it also stated in that article that a lot of the 150 is going to go into post-acute. So the problem is that we're not exactly sure where these 150 million tests will actually land. I do believe that eventually they will be in your space and you will have access to a $5 antigen test. Is that next week? Is that in November? Is that in December? That's what we can't tell you at this point. I kind of mentioned the green, yellow, or red. You can see that depending on where you're actually labeled, if you're in a county with red, so obviously a lot of COVID, then you're going to have to do testing more than a green facility would or a yellow facility. I also want to mention, especially for the state of California, that HHS basically came out and said that, listen, I don't care what your state is basically saying about antigen technology, but we supersede state level restrictions. So we're basically telling you that to do antigen testing is okay. Doesn't matter what the state says. Under the PrEP Act, we're superseding state level restrictions. We're also expanding you to let you know that, listen, this is proven technology and you can use this technology to off-label screen asymptomatic patients. So obviously you can test anybody with antigen testing. They don't have to be symptomatic at this point. I want to make sure that this is clear because there's a lot of questions about a reimbursement. I do these type of webinars across the country, and it's always a little different in regards to what people are doing, what they're not doing. But today, when I look at your environment, you obviously either do the test yourselves or you send them out. And when we look at Medicare Part A, obviously you're going to absorb that cost. We see across the country that labs are charging anywhere between $70 to $150 for COVID testing. So the nice thing is that at least we know that doing your own testing is less expensive. You can control when you're getting the results, so you don't have to wait. I mentioned, obviously, the Quidel system. It is $23 per test, and that's set by the manufacturer. The BD system, today it stands at $31.75 per test, but I can also tell you within the last 24 hours, BD came to us and they said, listen, we're going to lower Medline's acquisition price. So I do believe, probably by Monday, that test will be under $30 per test, and that Cepheid test is $38.50. What I've got on the screen here is that Medicare Part A, you're absorbing it, but Medicare Part B, you can actually bill for these particular tests. I've given you an example of a CPT code 87635. That is for PCR technology. There's also an antigen code, which we can share with you. I can tell you antigen typically reimburses at $45, so it reimburses more than obviously the cost per test. But Medicare Part B, you can bill. And I have a lot of homes say, well, we're not getting obviously bills from the lab for Medicare Part B, because obviously that's the reference lab billing directly Medicare Part B. So we can provide you with CPT codes, some guidance in regards to how to bill, but these are billable procedures. I do want to clarify though, we know, for example, with Medicare, Medicare is not going to pay for surveillance testing. So they're not going to pay for you to just test asymptomatic patients. But if a patient is symptomatic, that should be reimbursed. Obviously, there's a lot of private insurers. We can provide the CPT codes, and you can basically determine, are they going to reimburse? And then before we wrap things up here and give you a few moments to ask questions, if you do happen to have a moderately complex lab, or if you've got a highly complex lab, we have other solutions, and we have tests that are available today. Obviously, having a moderately complex or a high complex lab, what you would enjoy is obviously a lower cost per test and higher throughput. So you can do a lot more people at one particular time, and the cost to do so is less than when we talk about these point of care antigen and PCR technologies. So with that being said, I wanted to leave some time open for questions. And I don't know if Craig or John, if you had any other comments, but I definitely wanted to see what questions we might have.
Great.
Yeah, thanks very much. I appreciate that. Can I ask you a couple questions before we move to attendee questions, if we can?
Absolutely, and we can go back to any slides if there's a particular slide you want to see.
Sure. No, well, one of the things I wanted to know is, are there other components of the devices that a facility would need to purchase to maximize the efficacy of the actual device, regardless of whether it's the Sophia or the BD1? Are there special printers? Are there special cables? What are some of the other things that go along that they will need to purchase if they want to maximize the device itself?
Yeah, absolutely, and that's a great question. The BD Veritor, you've got a few different choices. So the BD Veritor, they sell an optional printer, so you can actually buy that direct. It's an optional Epson printer if you want to be able to print out the results. Or if you're interested under the CARES Act, if you've got to do some reporting, they have a software program. It's called the InfoScan. Roughly, it's a $400 software program, but that will allow you to use your software, download it to your computer, and then you can print out results and put some basic information about the test. So to your point, yes, with the Sophia unit, it actually will load the information into the cloud, but still, you're going to want to be able to print that information out or put it into a computer system. So both of these systems, there are some options that you probably would want to consider in regards to being able to report to the state. And we can obviously, you can follow up with us, talk to one of the Medline reps, but more than happy to provide that information to you.
Oh, that's great, thanks. And if they want to if they get to the point where they want to use these for flu, I'm assuming it's a different reagent, but I don't know that. And is it the same test that reads it, or is it a different test?
No, hey, that's a great question. And it depends on the technology. As I mentioned earlier, PCR, when we talk about that Cepheid unit, they're developing one cartridge that will do flu A, flu B, COVID, and RSV. But when we talk about the BD Veritor or we talk about the Quidel Sofia, it is a separate cartridge that will allow you to do obviously flu or strep or RSV. Some have a combination of flu and RSV, but it is a separate cartridge that you'll buy in a separate box utilizing the same device. So you're still utilizing the same device. As I look at this BD Veritor, it will do all three. And there's even a promo for the BD Veritor. If you're going to do flu, you can purchase the 2 flu kits and virtually getting the reader for free. When we look at that $5 card though, that will simply be COVID only. So obviously it will not be able to do flu or strep or RSV.
Okay. No, that's great. So in terms of supply chain, do you anticipate this to have better performance than the other? Are there issues with obtaining the supplies that will need to be constantly to use this? Do you think we'll run into issues with that? And if so, is there one that may struggle more than the other?
Well, the tough thing is that we never know what the government's going to do. So multiple times the government has stepped in and they have wiped out a company's supply of reagents. And as I mentioned with the $5 card, and we're not exactly sure what they're going to do with that $5 card. So things could change on Monday morning. Where we sit today, Cepheid, you're going to be waiting until January to be able to do the amount of testing that you want to do. But I'll go back to state this, there's no perfect solution. I think that is the best testing method available, PCR technology. So to utilize that, maybe in conjunction with one of these devices, the BD Veritor or the Quidel Sofia, I think is a fantastic idea. I think that today we know that we've got the BD Veritor hitting our warehouses as I speak. We started to receive trucks yesterday. BD tells us unless the government comes in again and wipes them out of inventory, we should have inventory for at least the next 30 to 60 days. So I feel fairly confident that we'll be able to get the customer base the reagents that they need for the BD Veritor. Quidel Sofia, we know that they continue to ramp up production. We hope that within the next 30 days, they'll be in a better place. But I can tell you most of these manufacturers, the later that we get into the COVID pandemic, they're becoming obviously better at producing. Many of these companies have opened up new facilities to produce COVID reagents. So every day gets a little better. As we sit here today, the BD Veritor is the product that we feel most comfortable with getting you the product.
Right. And that's good information for you guys on the call, because we know that you weren't given a choice. You were just sent whatever was in the warehouse at that time. So for some of you that have the Quidel device, you know, there may be operational issues with resupplying that. So in terms of,
I would encourage everybody, if you got the device, put your order in with your Medline rep, and at least we'll be able to come back to you and tell you how many assays you're going to receive.
Yeah, that's a great point. So Jamie, do we have any questions from the audience that we can run by our panelists, or questions for me?
We do have some questions here. Can you hear me okay?
I sure can, yeah.
Great. So our first question is, will Program Flex for staffing hours still be available after September 30th, 2020, when the last round of waivers expire?
Well, we don't know that. We not only have we asked them to continue that, but we've asked them to go back to a statewide waiver for staffing. Now, I'm not hopeful that we'll get much traction on that, but I think given the amount of time that it takes to process the testing and some of these other things where we're taking people away from direct care and being able to count that towards direct care hours, that is one of the critical things that we highlighted to CDPH, that we have to continue to understand the staffing component to this, and especially as we add more tasks onto care staff to be able to do this, it would reduce our ability to meet 3.5 and 2.4. So I don't know this for sure, but it's certainly a part of our C to CDPH, and we'll continue to ask them to just kind of bump that same AFL to a future date and continue to allow the 5,000A waivers. All right, next question, Jamie.
Great, so this is a question for Medline. Obviously, cost reduction for testing is very important, PCR pooled testing. Is there or will there be a pool test available for the, I apologize if I butcher this, Cepheid?
Cepheid.
Yeah, and I think that's a great question. By pooling, for those that don't know, obviously being able to test a large amount of people at one time, and you typically will look at a patient population that you think is healthy, and if you test them and it comes out negative, then everybody's negative. If it's one person's positive, then you've got to go back and find out who that person is. But absolutely, I can tell you Cepheid is a company that continues to work on technology. They're not telling us today that pooling is that technology, but all of these companies are looking for solutions where you can test a lot of people at one time for a low cost. And pooling definitely is one of those answers. So today, not available, but I definitely think that in the future it's available. And one thing to keep in mind with these tests is, let's face it, and we're seeing the reports now, people have foggy memories, they still have breathing problems, are extremely tired. We know that there are going to be other issues with COVID well beyond when we get a vaccine and hopefully COVID disappears. The problems will probably continue to linger. And that's why these types of technology, when I look at the Cepheid GeneXpert Express, it does have a unit that's moderately complex, but you can do things like C. diff and MRSA amongst a lot of 25 other different assays. So I think that bringing these type of solutions into your facilities, it's just not for the pandemic today. I think that we live in a different world, and we're going to be able to utilize these technologies as they continue to make them better going into the future.
Great, thank you so much for that answer. We have another question here. Is it safe to use even if it's FDA approved? They're referring to the BD device. It says it's not FDA approved. Is this true?
No, I haven't heard that. All these devices have been approved by, I can tell you, all of these devices have been on the market now for multiple years, 5-6 years. The Cepheid, the Quidel Sofia, the BD Veritor. The difference today is that they're EUA approved for doing COVID. They've been on the market for multiple years doing flu, strep, and RSV. So yeah, I mean, these are products that have been approved by the government years ago. The difference is that they have EUA approval today for COVID.
Yeah, and that EUA approval comes from the FDA. So yeah, and whether it's FDA approved for those other tests or whether that's even necessary, I don't know. But yes, it's my understanding that they're both FDA approved, those two specifically. All right, next question, Jamie.
Does Medline sell the compatible printer for the Veritor?
That printer you can buy actually direct. We'll give you that information. It's an Epson printer, and we can provide you that information, a website that you can go to, and you can buy that on your own.
Great,
So it's proprietary, but the manufacturer sells it. Is that correct?
Well, it's just an Epson printer, so
nice.
you can go out and get that printer. It's specifically for the device. No need to go through Medline for that printer.
Okay. Oh, that's great. Next question.
Would CAF be willing to develop a generic policy on the use of the BD machines?
Well, we could. I think the manufacturer actually has a pretty good education as to how to use the devices. If you're talking about a specific policy and procedure based on kind of the criteria or the algorithm, the testing algorithm that that CDPH is going to release, I think that's probably a good thing. We can add it as an addendum. If that's what you're looking for, incorporating like the testing algorithm from CDPH to say, okay, symptomatic staff, this is the process I use. Symptomatic residents, this is a process I use. Kind of a flow chart of, I go, PCR test for this, I do point of care for this, things like that. We can certainly do that, but frankly, a lot of this, when we talk about making decisions, especially clinical decisions about how we use a testing modality, a lot of it is going to be dependent on the actual patient presentation. If you're talking about, a resident or something like that, and what are the other options in your individual facility. So we can write something that's kind of generic based on the CDPH guidelines, but it would be more formulaic, and you would have to address your individual policies. And so anytime we create like the emergency operations plan that we have, or the mitigation plan that we created, those things are not meant to be a full solution for you. They're meant to kind of give you the formula and to have you fill in given your individual experience. And we just give you the format of how folks traditionally do that. And most of that is based on the response structure in acute care hospitals or in other entities. But we can build you the formula and how we think it's best to do it, but it really will rely on you individually making that determination for what's best. How quickly you can get PCRs. Like Doug said, if the PCR test is not coming back, then you've got to start thinking about using these POC devices, because I truly believe in lieu of that, the PCR is number one, but if we can't get it, then we've got to use the point of care testing devices. And so I think there's so much of each decision to how you do it in your facility that we can create a framework for it, but we can't give you super specifics. And if we did, it'd be a disservice because it wouldn't factor in everything. So, all right, next question, Jamie.
Next question we have is, we received the BD Veritor device. Is CMS going to send additional device once we have maxed out the use?
No.
Not to my knowledge, no. The initial shipment is what they're shipping, the initial 13,000 units, but I've heard no plans of them sending additional reagents or the units themselves. As I mentioned before, if you want an additional unit, $330, you could get an additional unit.
Yeah, and the Quidel or the Sofia device, that's a bit more expensive to purchase on your own, is that correct?
They've got some plans where the unit itself is $1,200, but they also have plans if you're going to do some flu and strep where you can get the device at no charge. But depending on how much flu and strep you're going to do will really dictate when you'll get that device. So we can put that device also into the marketplace, but that device today is on allocation. So it just depends on what you want to do, and we're more than happy to work on your behalf with Quidel to determine when you'll actually get a unit.
And I'll just piggyback on that. We've been told, now I've not seen this in writing, but we've been told by AHCA, our national association, that the first shipment is the only shipment that you guys are going to get, and all of the other components that go with it, you'll need to purchase those with your CARES Act funds to be able to support that. So, all right, the next question, Jamie.
All right, based on the CMS guidelines, it appears we are responsible to insured vendors. Consultants are tested. Can you use the BD devices to conduct tests for these individuals, and would this be sufficient?
Well, that's a great question, and that's one of those ones we're going to have to wait for the AFL, simply because there were multiple elements within that CMS QSO, and one of the hangups is you need a physician's order, and so we don't know how that will work. Will our in-house medical director be able to do those orders for folks that are not our employees? We don't know. We do know that they're going to be required to be tested, but how we capture that information, we've got to wait for the AFL. And a lot of that, we know that HHS has said that now you can use this as a screening tool. So based on that, I haven't seen it in writing from CDPH yet, but it would indicate that we would be able to use it just based on that kind of HHS documentation, but I don't know that for sure, and I'd only be guessing at this point until the actual AFL comes out. But I would anticipate you'll be able to use it for that, but I don't know that for certain yet. All right, next question, Jamie.
We have one more question. If facilities have to use the BD device, is it still the case that a negative result on the Veritor needs a follow-up PCR test?
It's considered presumed negative, so somebody has to make that choice. But if the patient is symptomatic, then you definitely want to reflex to PCR technology. It's going to be your determination if you're going to send the negative patients that are asymptomatic to a reference lab. It's considered presumed negative.
Yeah, and that is one of the key things that we will learn from the AFL once it comes out, is we will learn what CDPH, how they want us to use those devices. We've given them the algorithm that CDC created a week and a half ago that kind of gives that exact, it pulls out every scenario. Symptomatic, not asymptomatic, symptomatic resident, symptomatic staff, asymptomatic resident, asymptomatic staff, and it has a decision-making tree below that based on the results of one of those tests. And we anticipate that that's going to be well defined in the AFL, and that will direct, how and when you use those devices and what, if any, follow-up tests you need to do as a minimum. That doesn't mean that you can't have your own policy to say, I'm going to do this and that. You can do that if you feel like that's the best decision, but we won't know what the minimum expectation is until CDPH releases the AFL. All right, next question, Jamie, or is that it?
That is all the questions we have at this time.
Well, fantastic, guys. I want to say thank you so much to the folks from Medline to coming on and sharing that information. You guys know that most of the, well, let me ask you one more question, Doug. When they will need to purchase equipment, supplies for either one of these devices, is the only way to purchase those through a distributor?
Correct. It's sold only through distribution.
Right. So they're not going to go onto the website of those manufacturers and start ordering the supply kits, correct?
No, if you do, it's going to push you to either us or one of our competitors.
Okay. All right. So I just wanted to cover that. Yeah. So you guys definitely have to think that process out of how you're going to get those supplies as well. So thank you very much.
Yeah. Any questions at all, reach out to us, and that's on any type of medical lab equipment, CBCs, chem, whatever the case is. More than happy to help.
Yeah, and I did not have their contact information on my slides, but if you guys, Jamie, can you put up my the last slide from my slide deck, and it has that email address? I don't know if you're able to do that, but if while Jamie's trying to do that, if it's possible, you guys can always info@caf.org. Just ask for the contact information for Doug and his team, and we'll direct you to the right person that has, if you have questions about that stuff. And I just wanted to point out that, we have multiple web pages with resources, not just for coronavirus, but also for disasters in general, as well as recordings are on our CAF TV channel. So with that, I want to say thank you very much for joining us this Friday. You guys have a smoky but relaxing weekend, and we will talk to you next week. Thanks very much, guys.
Thank you.